Teaching Module 1C, Drugs. Teaching Module 1C, Drugs. Memorization musts for lithium. Therapeutic index of only 0.5 to 1.2. The toxic level of 1.5 or higher is too close for safety. It requires close monitoring of levels and patient education. It is the standard treatment for manic episodes and has a reputation for reducing suicidal behaviors. It is also neuroprotective for bipolar disorder. The required lab tests are TSH, creatinine, BUN, HCG, and an EKG for patients over 50. The mnemonic for the lithium side effect profile. LITHIUMSFX. Okay, we're adding another S to the lithium SFX. Lithium's SFX. Low therapeutic index, intestinal upset, tetragenicity, hypothyroidism, interactions, urination, muscle weakness, slurred speech, blurred vision, skin, fatigue, extra pounds. Repetition on the lithium side effect profile using lithium SFX. L. Low therapeutic index, 0.5 to 1.2, toxic at 1.5. Intestinal upset, diarrhea, vomiting, cramps, and anorexia. Tetragenicity, hypothyroidism. Interactions, thiazide loop diuretics, NSAIDs, ACE inhibitors, angiotensin II receptor blockers. Urination, diabetes insipidus, polyuria, polydipsia, edema, microtubular changes. Muscle weakness, fine hand tremors. Skin, maculopapular rash, pruritus, acne. Fatigue, avoid with rapid cycling monotherapy, and extra pounds. Remember T-wave inversion and leukocytosis. Standard treatment for manic episode and lowering suicide ideation events. 1.3 lab, observe for symptoms. 1.4 lab, observe for symptoms. 1.5 lab, stop the med and check the labs. Neuroprotective for bipolar disorder, mania aspects. Hematologic leukocytosis. Maculopapular rash. Cardiac. T-wave inversion. Dysrhythmia. Did your mother use lithium? Fine hand tremor is a side effect. Coarse hand tremor is toxicity. Renal. Diabetes insipidus, polyuria, polydipsia, edema, microscopic tubular changes. Mnemonic for lithium toxicity. Starting down Confusion Boulevard might come from ingesting lithium. The mnemonic for lithium toxicity. Severe nausea and vomiting, diarrhea, confusion and drowsiness, blurred vision, slurred speech, muscle weakness and ataxia, coarse hand tremors. Immediately stop med and check levels. Valproic acid side effect profile. More effective than lithium for rapid cycling depression. vomiting, alopecia, liver damage, pancreatitis, rebound seizures, ovarian cyst, interactions, CBC abnormalities, spina bifida, fatigue, extra pounds. Value your liver. Rapid value used for rapid cycling. 50 to 125 keeps you alive, labs. VPA IQ drop, cognitive impairment. VPA opens up smiles in the wrong way, cleft palate, lip. VPA closes the case but not the neural tube. Carbamazepine side effect profile. CARBSFX. CBC abnormalities. Adjustments. Rash. Baby. Sodium abnormalities. Fatigue. Extra pounds. CBC, decreased white blood cells, agranulocytosis, aplastic anemia, pallor, fatigue, headache, fever, nosebleeds, bleeding gums, skin rash, shortness of breath. Rash, Stevens-Johnson syndrome, particularly in Asian individuals, HLAB 1502 allele before initiating. Baby, always check pregnancy status, HCG age 12 to 50. Add folic acid, supports neural tube development during the first month of pregnancy, 0.4 to 0.8 milligrams daily. For sodium abnormalities, we're talking about hyponatremia. Monitor electrolyte levels periodically during treatment. For fatigue, we're talking about central nervous system side effects. Dizziness, drowsiness, and ataxia are common. Monitor and adjust the dose as needed. And don't forget the extra pounds. Therapeutic range monitoring. Maintain levels between 4 and 12 for seizure control. Mucous membrane pain before rash onset, arthralgia as a prodromal symptom. The drug itself is a liver enzyme inducer. Oral contraceptives and warfarin beware. Hyponatremia. Aplastic anemia will show with fever, fatigue, nosebleed, and bleeding gums. 3 A's. Aplastic anemia, Asian population, agranulocytosis. Liver enzyme inducer. Carbamazepine may decrease the efficacy of other drugs metabolized by the liver, especially oral contraceptives and warfarin. HLAB 1502 for Asian population. Add folic acid, supports neural tube development first trimester. Lamotrigine. LAMICTAL. Lamotrigine. Acute management and prevention of bipolar mood episodes. Mucous membrane pain before rash onset. Interactions with CYP450 inducers and inhibitors. Close observation needed during initial treatment. Titrate dose gradually, starting at a low dose. Arthralgia as a prodromal symptom. Look out for life-threatening rash, Stevens-Johnson syndrome. High yield facts. Black box for SJS, DC the Med, Stevens-Johnson syndrome. Fever, sore throat, facial swelling, tongue rash, and skin sloughing. Prodromal headache, malaise, arthralgia, and painful mucous membranes. These might occur before the rash occurs. Therapeutic use, effective for managing acute episodes and preventing bipolar mood episodes. Starting dose and titration, initiate at a low dose like 25 milligrams a day and increase gradually to avoid severe rash, typically titrated over several weeks. Drug interactions. Efficacy may be reduced when used with inducers or enhanced with inhibitors of CYP450 enzymes. If the rash disappears, resume medication. It is not Stevens-Johnson syndrome. Monitoring parameters. Observe patients closely for mood changes, suicidality, and unusual changes in behavior during initial treatment. Metabolic syndrome. First sign is lipid levels and waist circumference. Waist circumference is first. Mastering all that is using clozapine. Risk of neutropenia requires monitoring the absolute neutrophil count, ANC, only, not in conjunction with a white cell count. Monitoring schedule. Weekly for the first 6 months, every 2 weeks for the next 6 months, then monthly if ANC is normal. White blood cell range 4,500 to 11,000. DC Clozaril or carbamazepine if ANC is less than 1,000. DC Clozaril or carbamazepine if WBC is between 2,000 and 3,000. Keep an eye out for infection signs such as fever, chills, sore throat, or weakness. The clozapine mnemonic. Closely monitor labs. Look out for ANC less than 1,000. Observe for symptoms of fatigue and weakness. 0 on achy, sore throat. Assess for pyrexia. Prepare for increased infection risk. Inspect for nippy chills. Note weight. Endocrine changes. Shotgun facts. Clozapine may cause increased salivation, seizures, and myocarditis. Smoking cessation can significantly increase clozapine blood levels. It is reserved for treatment-resistant schizophrenia or suicidal behaviors in patients with schizophrenia or schizoaffective disorders. Stop the medication at the first sign of infection. Work on mastering olanzapine and clozapine. Important facts on olanzapine. Metabolized by the P450 enzyme CYP1A2. If a patient starts smoking while on olanzapine, their dose may need to be increased. Potential interactions with enzyme inducers, such as tobacco and carbamazepine. If a patient stops meds, their olanzapine dose may need to be decreased. Olanzapine is Zyprexa. 2 important things to measure: lipid level and abdominal circumference. Metabolic syndrome. First sign is increased waist circumference, elevated triglycerides, hypertension, hyperglycemia, insulin resistance, low levels of HDL, obesity characterized by excessive fat around the waist and abdomen. Clozapine, metabolized mostly by P450 enzyme CYP1A2. Enzyme inducers can decrease serum levels, tobacco and Tegretol. Enzyme inhibitors can increase serum levels of substrate drugs, clarithromycin, ketoconazole. Similar interaction potentials. Monitor patients for metabolic syndrome. Olanzapine, high yield. Understand the metabolism pathways of olanzapine and clozapine through the P450 enzyme CYP1A2. Watch for Arcus senilis as a possible indicator of hyperlipidemia in younger adults. Recognize the possible impact of enzyme inducers and inhibitors on medication dosage adjustments. Be familiar with metabolic syndrome signs, particularly monitor lipid levels and abdominal circumference. Remember that smoking status plays a significant role in adjusting the dose of olanzapine. We're now going over the essential medicines, the shotgun facts about several key medications we need to know. Bupropion, Wellbutrin. It is an NDRI. Be mindful that Wellbutrin decreases the seizure threshold. It's contraindicated for seizure disorder, a history of seizures, TBI, bulimia, anorexia. Priapism is a prolonged erection. Wellbutrin and trazodone here. It boosts neurotransmitters, norepinephrine and dopamine. Only one key fact about Lexapro. Never forget, it has a low drug-to-drug interaction rate, and this is essential. Only one key fact about Lexapro. Never forget, it has a low drug-to-drug interaction rate, and this is essential. Or sertraline, Zoloft. Low drug-to-drug interactions, particularly with Lexapro. Sertraline is selectively safe among SSRIs. Clomipramine, which is a TCA, helps with chronic pain but is not as safe as SNRIs. Clomipramine clings to pain therapy, but caution with safety. Clomipramine for obsessive compulsive disorder. Duloxetine helps with chronic pain. Duloxetine dials up serotonin and norepinephrine to relieve intense pain, SNRI. Duloxetine, dual mechanisms, serotonin and norepinephrine. Duloxetine dulls pain. Gun facts. Remember the contraindications for each medication. Understand how different medications interact in combination therapy. Familiarize yourself with the dosing range and titration schedules for different medications. Be aware of the side effect profiles for each medication. I'm going to go over the basic tetragenic risks for several medications. It's benzodiazepines that give us floppy baby syndrome and cleft palate and lip. Example for the mnemonic: benzo sounds like bend, so think of bendable or floppy baby. Carbamazepine number 1, neural tube defect. Lithium, low implanted tricuspid, Epstein's anomaly. Side effect versus toxicity. Side effect: acne, weight gain, fine hand tremor, maculopapular rash. Toxicity: coarse hand tremor, T-wave inversion, aortic stenosis, leukocytosis, renal issues. Valproex sodium, Depakote, neural tube defect. Benzodiazepine withdrawal symptoms in newborns such as irritability, hypertonia, and tremors should be noted. Carbamazepine is an enzyme-inducing antiepileptic drug so that it may have significant interactions with other medications. Divalproex sodium is known for its hepatotoxicity and pancreatitis risk. Therefore, liver function and pancreas tests should be conducted routinely. Lithium should include close monitoring of serum levels and adequate hydration, as it can cause nephrogenic diabetes insipidus. Managing hypertensive crisis. Causes: meperidine, stimulants, sympathomimetics, decongestants, TCA atypicals, St. John's wort, L-tryptophan, asthma medications. Of course, aged foods and wines. First action: stop medication, MAOIs. Administer phentolamine. It's an alpha-adrenergic antagonist to lower the blood pressure. Stabilize fever using antipyretics or cooling measures. Symptoms: elevated BP, sudden, explosive headache, facial flushing, palpitations, pupillary dilation, diaphoresis, and fever. We're going to work here a few minutes on understanding the differences between serotonin syndrome and neuroleptic malignant syndrome. Serotonin syndrome is caused by antidepressants like SSRIs, TCAs, MAOIs, and SNRIs. When switching from an SSRI to an MAOI, wait 2 weeks. When switching from MAOI back to SSRIs, wait 2 weeks. When switching from Prozac to MAOIs, wait 5 weeks. Typically lasts 1 to 3 weeks. An example: taking both an SSRI and an MAOI simultaneously. The treatment for serotonin syndrome: stop the med and use cryptoheptadine. The four-sailed method for mania inducers. Syphilis, SAMI, steroids, St. John's wort, ginseng, antidepressants, isoniazid, levothyroxine, disulfiram. In MS treatment, stop the med, treat with bromocriptine and/or dantrolene. Similarities and differences. Similarities. Both present with fever and altered mental status. Differences. Serotonin syndrome characterized by hyperreflexia and myoclonic jerks. NMS characterized by muscle rigidity, mutism, autonomic instability, lead pipe. Remember that combining SSRI with St. John's wort or using more than one SSRI can potentially lead to serotonin syndrome. A chart here where you can see the causative medications, the physical exam findings, the laboratory findings, and the course of the illness. One more time on the serotonin syndrome mnemonic. It's too many serotonergic drugs. Shits and shivers. Shits, shivering, hyperreflexia, increased temperature, vital sign instability, encephalopathy, restlessness, and sweating. Serotonin discontinuation syndrome, mnemonic, finish. Flu-like symptoms, insomnia, nausea, imbalance, sensory disturbance, hyperarousal. Unmask mania with the four-sailed method. The four-sailed method for mania inducers. Syphilis, SAMI, steroids, St. John's wort, ginseng, antidepressants, isoniazid, levothyroxine, disulfiram. Always consider the possibility of drug-induced mania in patients presenting with new onset symptoms. Monitor patients closely when initiating medications known to potentially induce mania, especially those with a history of mood disorders. Treat drug-induced mania by discontinuing or adjusting the causative medication and consider pharmacological intervention such as mood stabilizers or antipsychotics if necessary. Educate patients and their families about the signs and symptoms of mania to ensure prompt recognition and management. Demystifying depression-inducing medications. Remember, ASAP at beta bis. For depression causers, it can be caused by antiretrovirals, steroids, Accutane, progesterone, antineoplastics, beta blockers, benzodiazepines, interferon, statins. Be aware of medication indications. Monitor patients for signs of depression during treatment and with these medications. Understand the risk factors for depression and possible biochemical mechanisms linking these medications. Interferon, often related to liver disease and its effect on first-pass metabolism, leading to toxic levels. Example, ribavirin.